Yeah, I see everybody doing travel.
All right. Hello, everyone, and thank you for joining us. I am Jessica, the community health worker with Pointe Inc. Sickle Cell Agency. We're going to give everyone another moment to hop on the call. So if you would just be patient with us and we'll start shortly. I thank you. All right, sorry guys, but if you would just give us another moment, we still have people trickling in. We will start shortly. I'm thinking 6:03, but once again, thank you all for joining us. All right. So we still have people coming on, but we're just gonna jump right in. Once again, I am Jessica, the community health worker with Bridges Point Inc. Sickle Cell Agency. And today we're going to be having a discussion on the FDA approved gene therapies for sickle cell disease.
Hi, Jessica. Do you want me to just, oh, actually, I'm sorry. You probably need my camera on. Um,
Hi, Phil. If you would, one moment, and we're gonna have you take over the floor. Just one moment, please.
no problem.
And you can turn your camera on as well. All right. So before we jump into the presentation, I just wanted to bring it to everyone's awareness. We do have some upcoming events. If you are a transitional age patient who receives care at Duke Medical, on the left side of the screen, you will see a flyer for the transition support groups. They're held every fourth Wednesday, and the next is February 28th at 5:30. You're able to scan the QR code only if you are a transitional age patient who receives care at Duke. For the second flyer, you'll see the Women's Health Awareness event. We will be setting up an educational booth at the Women's Health Awareness event, which is on April 13th. You may also scan the QR code for this event. It's a free event as well. So I thank you guys.
And good evening. My name is Shanika Richardson with Bridges Point Incorporated. Thank you for joining us again. In this webinar, we will have a presenter from Bluebird Bio, followed by Duke Medical. We will have a brief Q&A session for each presenter. Due to unforeseen circumstances, Dr. Shaw will not be joining us tonight. However, Dr. Strauss is well prepared to cover for Duke. Thank you, Dr. Strauss. And a few items we want to mention, there is a button at the bottom of your screen for Q&A. Please place your questions there and we will try to cover as many of them as we can. There is also a closed or show captions button at the bottom that you can enable for your screen. Please note we will have two polls during this webinar and one that will pop up now on your screen. We thank you in advance for your participation and for attending this call. And Jessica, you can play the poll.
Okay, here one moment. So on your screen, you'll see the first poll question. Everyone can review it, and I'm gonna give everyone maybe like 30 seconds. I see the polls coming in.
Thank you. And once the poll is off your screen, then Bluebird Bio can begin. Phil, I'm not sure if you had an additional question.
You guys have a view of Zoom that is new to me. I do not see the option to turn on my camera. So
Gotcha.
I just see audio settings, chat, lower hand, Q&A polls.
Okay, let's see if I can fix that for you.
One moment. You should be able to turn on your camera now. Do you see the option to do so?
It says that it stopped for me at least. I can't, even though I can see the icon, it won't let me start the camera.
Okay,
It's disabled by the host.
okay. Here, one moment, guys.
If you want, we can change the role to attendee.
Well,
See,
the panelist mode, I do have the option to start video, but it says I cannot start video because the host has stopped it.
okay.
So I think we might be on the right track, but
So I'm gonna stop mine. Maybe that will help.
All right, so I stopped sharing my screen. Azizi, you should be able to share yours. And Phil, you can start presenting and I'll work on the features on my end to see if I'm able to have you share your screen.
Hey, Phil, can you see my slides?
I can see the slides. Can you guys hear me okay?
Yes.
All right. So I'm still not getting the option to start video, but that's okay. I will go ahead. And I just wanted to first off, just thank Jessica, Shanika, and Bridges Point for allowing us to come and present. We're excited to be sharing with you guys about our new gene therapy option that is now approved. But it is a privilege. My name is Phil Okwo. I'm a sickle beta zero thalassemia warrior myself, and father of two based in the Atlanta, Georgia area. And I'm thrilled to be joining as a director of Bluebird's patient and community education team, of which Azizi is one of our liaisons. And some of you guys already know Azizi, but our goal, our mandate is to ensure that these new options for gene therapy, that the community is able to get as much awareness on the various options that exist, and answer all the ways you can get resources and information that you need to help make a decision. But with that note, as you see here, I am a representative of Bluebird Bio. And why we do what we do is very much in the name of our organization. And so I don't know how many folks on this call are familiar with the skiing term called a Bluebird Day. But a Bluebird Day is kind of one of those days. It's like a perfect day, clear skies. It's usually after a storm or snowfall the night before. And so we are in the business of bringing Bluebird Days to people with conditions that are genetic, unpredictable, and progressive. Conditions like sickle cell, but also like thalassemia and CALD, or cerebral adrenoleukodystrophy, for which Bluebird Bio already has 2 prior FDA approvals in the gene therapy space. And so with that, if there are any patients and or caregivers on the line who are looking for more Bluebird Days for their warrior, please definitely stay tuned and get some good information. Next slide.
And Phil, you may be able to start your video now.
Oh, okay.
Thank you.
You guys see me? All right. So thank you again to Bridges Point for inviting us to come and speak today. I and Azizi are employees and shareholders of Bluebird Bio. We have a couple of other members of the flock who will probably be joining in shortly from another presentation we had just a few states north from you guys. But this presentation is intended for an audience 18 years of age and older. And most importantly, because I'm not a doctor, but thankfully we have some doctors on the line, but it is not intended to provide medical advice or make treatment recommendations. So please do take the information you hear in this presentation and discuss it with your doctor. Next slide. So today we're going to talk a little bit more about Bluebird Bio. We're going to talk about Lyfgenia as a treatment. We're going to talk about what it is, how to say it, what's important information you should know from our label, from the FDA approval, as well as some resources in Lyfgenia that can help you find out where the closest qualified treatment center is to you. How to get in touch with our My Bluebird support team, which is our team of patient navigators who are here to help you every step of the way. And whether you have a prescription for Lyfgenia or not, whether you're a patient with sickle cell or not, they're great. And so stay tuned for info and connecting with them as well. And then additional resources that are on the way to help further educate the community through organizations like Bridges Point. So again, Bluebird Bio is a company that's been dedicated to gene therapy for a number of severe genetic diseases. Bluebird has been in the space leading gene therapy research for over 10 years. And this sickle cell treatment is our trifecta, is our third FDA-approved gene therapy, this one for sickle cell, and again, the prior to being for transfusion-dependent thalassemia and CALD, or cerebral adrenoleukodystrophy. But Bluebird has been very, very committed to patient access. As a consequence, we are working actively with, at the moment, somewhat over 40 qualified treatment centers to deliver Bluebird gene therapy to patients. And we anticipate that number will be upwards of 60 qualified treatment centers by the end of the year. But we've also been able to have, by way of years-long engagement with payers, including Medicaid, the opportunity to remove barriers to access. And we've been proud to say that with our prior two FDA-approved gene therapies, we've been luckily to date to have 0 ultimate payer denials. So that is definitely a testament to our commitment to providing access for those who desire to go down this gene therapy journey. Next slide. All right. So we're going to learn a little bit about Lyfgenia. Again, this is Bluebird Bio's gene therapy that was approved in December 8th of 2023. Next slide. So first, I always like to say, if you're like me, I'm never sure how to say so many of these names of the various treatments, but Lyfgenia itself, I kind of like it, rolls off the tongue for me more than some others. And so the pronunciation, pretty straightforward, Lyfgenia, right? Lyfgenia. And so, practice it a little bit. But also while you're practicing it, a lot of the information from this presentation will be available at lyfgenia.com. And so if you want to follow along and dive into the details of our prescribing information and our medication guide from the FDA approval, you are very welcome to do so. And as we go, we want to try to make this as conversational as possible, but please feel free to drop your questions as we go, so we can address them afterwards. All right. So Lyfgenia is to date the longest studied approved gene therapy for sickle cell disease. The primary clinical trial that evaluated Lyfgenia actually began in February 2015. As you can see here, this asterisk, this notation below. But a few of the hallmarks of the Lyfgenia treatment are that there is no donor needed, which is a game changer, especially since the community has often had challenges finding full match donors. The Lyfgenia treatment is special because it uses the patient's own blood stem cells to help develop the treatment. It is for people with sickle cell ages 12 and older with a history of vaso-occlusive events. So this maybe preempt some of the questions, but this is irrespective of genotype. At age 12, with a history of vaso-occlusive events, qualifies as part of the indication for whether or not this treatment applies, of course, in conjunction with discussions with your doctor. But finally, it's also Lyfgenia is designed to allow for the production of enough anti-sickling hemoglobin to potentially decrease or stop altogether vaso-occlusive events. Next slide. And so for these reasons, we're so excited to bring Lyfgenia to the community. It is a one-time gene therapy to treat sickle cell disease. That one-time treatment is made up of a number of phases, the specifics of which we'll get into in subsequent slides. But for those who don't know, sickle cell is a genetic inherited lifelong disease that is caused by an alteration of the genes in the red blood cell, the beta globin gene, which causes the normal disc-shaped red cells to take the shape of a sickle that causes anemia and vaso-occlusive events like pain crises. Lyfgenia is made specifically for each patient and uses the patient's own blood stem cells and adds functional copies of the beta globin gene to your cells, which is what leads to the production of that anti-sickling hemoglobin that may ultimately decrease or stop vaso-occlusive events. And so in the spirit of being fair and balanced, as excited as we are, we do have some important safety information per the FDA approval that everyone should know when considering Lyfgenia. Patients who have been treated with Lyfgenia have developed cancers of the blood treatment with Lyfgenia might increase one's risk of developing a blood cancer. It could develop after many years of treatment with Lyfgenia, and it can be life-threatening and or cause death. Now, because of the risks, you should talk to your doctor about the benefits and risks of Lyfgenia and about your treatment options. Your doctor may evaluate if you have risk factors that could increase these chances after the treatment, after Lyfgenia treatment. Because of this risk, it is important for you to be monitored at least every 6 months for a minimum of 15 years after Lyfgenia. Monitoring will include blood tests that measure your blood cell counts and evaluate the blood cells where the gene product is present with specialized tests. Should these tests be abnormal, additional testing might be recommended by your doctor. And additional testing could include more frequent blood tests to watch you more closely for changes in your blood. Could also include bone marrow evaluation, which can tell your doctor if a blood cancer is developing. Next slide. Although blood cancer may have no symptoms, some symptoms could also be general. You or your caregiver should call your healthcare provider right away if any of the following signs or symptoms are observed. They could include abnormal bruising or bleeding, inclusive of a nosebleed. Could include blood in urine, stool, or vomit. Coughing up blood. Severe headache. Unusual stomach or back pain. A fever of 100.4 degrees Fahrenheit or higher. Swollen glands, abnormal tiredness. And if you are diagnosed with a cancer or have your treating physician, contact Bluebird Bio at 1-833-999-6378. You might experience side effects associated with other medicines administered as part of the Lyfgenia treatment regimen, and so you should talk to your physician regarding those possible side effects. Your providers may also give you other medicines to treat those side effects. It is important that you or your caregiver tell your healthcare providers that you have received Lyfgenia. Next slide. So some of the resources we've been sharing, we've been excited to make available to the various community-based organizations like Pointe and MSCDA and Sickle Cell Disease Association of Illinois include the following. Next slide. The first is Lyfgenia.com. And so for those of you who are who did not yet take our invitation to jump to Lyfgenia.com, I'll invite you again to do so now. Lyfgenia.com, again, is not just going to include some of the information in this presentation, but it's going to include kind of comprehensive info on our PI or prescribing information as approved by the FDA. It will include more in detail on our medication guide. It will also have an opportunity to sign up for email updates, not just about other educational opportunities like these, some in partnership with local CBOs, some in partnership with qualified treatment centers. The Lyfgenia.com will also guide you. There's a link there that would actually help you find the closest qualified treatment center to you, and as well as the means of contacting My Bluebird Support, which is the name of Bluebird Bio's patient support services team. We have patient navigators who are available on standby to talk to you directly, with or without a prescription for Lyfgenia, and whether you yourself are a patient or not. We're there to help to continue the conversation or navigate next steps at any stage in consideration of pursuit of a gene therapy. Next slide. Actually, it's easy if I could get your assistance with dropping that Lyfgenia.com in the chat if you haven't already. So about the Lyfgenia Qualified Treatment Center Locator. So at the moment, including Lyfgenia, but also the other Bluebird Bio treatments or gene therapies that have been previously approved, we have at the moment over 40 qualified treatment centers across the country. And we anticipate that by the end of this year, that will be upwards of 60 qualified treatment centers. Bluebird Bio has been dedicated and committed to ensuring, to actually meeting patients where they are. And so it is our goal to have a qualified treatment center where one can access Lyfgenia treatment We expect these to be within 200 miles of the vast majority of the sickle cell population in the United States. And so the QTCs, Lyfgenia is only administered at these QTCs, but a QTC is a specialized hospital that qualifies to administer a Bluebird Bio gene therapy. Each Lyfgenia qualified treatment center has been carefully selected, not just based on their expertise in areas of transplant and cell and gene therapy, but also based on their expertise in the area of sickle cell. And they have been trained specifically on the Lyfgenia product and how to administer it. So for those who want to learn more about the QTC near them, visit lyfgenia.com/find-a-qualified-treatment-center. Next slide. All right, my Bluebird support. This is our team of patient navigators. For anyone who is considering that this one-time Bluebird Bio gene therapy, our hope is to make sure that you are supported at every step and at every stage. And for this reason, we've created our My Bluebird support team as a source for a number of educational resources aimed at helping you or someone you care for stay informed in the decision-making process. Our patient navigators can help answer additional questions about the treatment process, navigating insurance, which has been a big curiosity for a lot of folks, and also in identifying qualified treatment center options. So again, here's an opportunity to contact a Bluebird Bio patient navigator via phone at 833-888-6378, via email at mybluebirdsupport@bluebirdbio.com, or directly on their website at mybluebirdsupport.com.
Hey, Phil. Also, the chat is not enabled. So if you will, like, just repeat your the link to mybluebirdsupport.com. If you just do that a couple times, because we can't drop it in the chat.
No problem. No problem. So the link to mybluebirdsupport.com is my Bluebird, BLUEBIRD, support, SUPPORT.com. And via email again is mybluebirdsupport@bluebirdbio.com. And one of our patient navigators can also be accessed by phone at 833-888-6378. Thank you for that, Azizi. So with regards to the educational resources that are going to be available soon, we have our patient consideration brochure, which we're very excited about. It's a detailed brochure available both printed and digitally that introduces Lyfgenia as a potential gene therapy treatment option and provides info to better understand what it is, how it works, the steps to treatment, safety info, clinical trial data, and available resources for support. The patient starter kit, and so these are available upon request. Definitely reach out to Azizi for those if you're interested, if there are patients in the community who would want to learn more about what should be taken into consideration as they, informed consent process. There's also soon to come a patient starter kit, which will be provided to individuals who are considering gene therapy. Oh, one more.
Sorry.
That's all right. Here we go.
One more.
Individuals who've been prescribed Lyfgenia with resources to support as they move through the treatment process. And so that would be once one has made the decision to move forward with Lyfgenia, they'd be able to access the patient starter kit. And then there's Lyfgenia.com, which, for those who are there now, it's got a lot of important information, again, including the prescribing info and the medication guide. But we do have an expansion in the works. And so we're going to help enhance the digital presence at Lyfgenia.com to help educate individuals with sickle cell about Lyfgenia. All right, and so in the spirit of again, the staying in accord with our FDA approval, we do have some ISIs or important safety information, or continuation of them about how one goes about receiving Lyfgenia treatment. So prior to treatment, your doctors will give you other medicines, including a chemotherapy regimen that is a part of your treatment with Lyfgenia. It's important to talk to your healthcare provider about the risks and benefits of all medicines involved in the treatment. And you would be admitted to a treatment center during this process. More details to come in step 3. After receiving chemotherapy, it may not be possible to become pregnant or father a child. And so one should consider discussing options for fertility preservation with your doctor prior to receiving treatment. Now in step 1, Lyfgenia is customized for each individual patient directly from their own blood stem cells. This is why there is no donor needed, which again can be such a challenging part if anyone considering such a treatment. Your healthcare provider will collect your blood stem cells through a process known as mobilization and apheresis. A lot of times we just refer to it as apheresis. This process takes approximately 1 week and may need to be repeated to obtain a sufficient number of cells. And while the apheresis process, as part of collection of cells through that process, there will also be a collection of what we call backup stem cells or rescue cells. Now, these are collected and stored at the treatment center as well, and they are done in a precaution in case there is a problem with the treatment process. Should that happen, your backup stem cells will be given back to you, and if you are received the backup cells, you would have no benefit from Lyfgenia. Now, as part of step 2, the cells that are collected through the apheresis process are then sent to a manufacturing site where they are used to make your customized Lyfgenia treatment. It typically takes roughly 10 to 15 weeks, about a little over about three months, give or take, from the time your cells are collected to make and to test Lyfgenia before it is shipped to your healthcare provider. But again, 10 to 15 weeks, give or take. Next slide. So for step 3, before you receive Lyfgenia, your healthcare provider will give you chemotherapy for a few days to make room in the bone marrow. This is a procedure we call conditioning. You will be admitted to the treatment center for this step and remain there until after the Lyfgenia is infused. In step 4, Lyfgenia is then infused intravenously. You might receive more than 1 bag of Lyfgenia, depending on how much is collected during that apheresis process, but each bag is infused in roughly 30 minutes or less. And after Lyfgenia infusion, you will stay in the treatment center for roughly 3 to 6 weeks so that your healthcare team can monitor your recovery and determine when you can go home. So a lot of buildup, definitely the process to collect those cells, but then to actually customize it directly for each patient. And in a whirlwind, it's kind of done. 30 minutes or less for each bag of infusion, and a period of monitoring before discharge to go home. After receiving Lyfgenia, one should not donate blood, organ, tissues, or cells. All right. So again, a review of some of the possible side effects of Lyfgenia. On the day of treatment, some side effects might include low blood pressure and hot flush. Following Lyfgenia treatment, some potential side effects could include blood cancer and longer time for platelets to recover. This may reduce the ability of blood to clot and may cause bleeding. These are not all the possible side effects of Lyfgenia, so do call your doctor for medical advice about side effects. You are encouraged to report negative side effects of prescription drugs to the FDA by visiting www.fda.gov/medwatch or by calling 1-800-FDA-1088. It is important that you have regular checkups with your healthcare provider, including blood tests at least every 6 months as advised by your healthcare provider in order to detect any adverse effects and to confirm that Lyfgenia is still working. So do talk to your healthcare provider about any concerns. Now, patients treated with Lyfgenia are encouraged also to enroll in a post-marketing study to assess the long-term safety of Lyfgenia and the risk of blood cancers occurring after treatment with Lyfgenia. Patients should discuss the option to participate with their physician. Lyfgenia will not give you an HIV infection. Treatment with Lyfgenia may cause a false positive HIV test, result by some commercial tests, in particular the PCR-based tests. But if one needs to have an HIV test, you should talk to your healthcare provider about the appropriate test to use. Once again, the full prescribing information and medication guide are available at lyfgenia.com. Next slide. And that is it. So with that, we would definitely want to open it up to questions. And again, just to thank you for the invitation to come and share a little bit more about the treatment with you guys. And I'll do my best to answer as many as I can before I have to jump. I have one more presentation at 7, so I would have a hard stop by then, but hopefully Azizi might be able to stick around and answer some. And I think some of my our other birds may have joined the call since.
Yes, they are on, and I know that they were able to drop the links in the Q&A section.
Okay, wonderful.
Yes, but I don't see any questions, and I do see Brenna is on. Jessica, are you able to give Brenna a panelist view as well? So she may need to chime in on some of the questions.
Yes, I'll give her a panelist view as well. But just for everyone else in the call, we do have a second presenter, so hold on tight. But yes, I'll let you guys open the floor for questions as well.
And hey, Dr. Strauss, good to see you.
Azizi, can you give me her name once more?
Yeah, Brenna. What's Brenna's last name, Phil? It's
Filipello.
Filipello. Yes.
Yeah. Okay.
And everyone, please place your questions in the Q&A. You can see that button at the bottom of your screen. Feel free to ask any questions now. Okay, I do see a question. What sample size was included in the study? Based on that size, what percentage of patients have developed a blood cancer thus far? Do we want to take that question and then?
Yep. So we had actually I'll let Brenna correct me if I'm wrong on this, but I think the number we had total transplant that were actually transplanted was 36. And of which 32 received had the endpoint of VOE efficacy. And so that was an elimination of the vaso-occlusive events. But with regards to the question around the number of blood cancers, probably I think Brenna, I may need your assistance with that one.
Yes, 3.
3?
Yes, sir. And she can answer. I don't think Jessica gave her access, right?
Yeah, I'm attempting to give her access, but I believe only a certain amount of people can be a panelist. But
And you can take me off as a panelist.
Okay. Okay.
And we're going to just take this one question and then we'll move on. But if you have additional questions, we'll make sure that we get them answered. We get the answer to you.
Yes, and I will also put my email address and telephone number, contact information in the chat or in the Q&A section as well, Shanika.
Thank you.
Mm-hmm.
I
heard Brenna may be able to just type the answer in the question in the Q&A.
Yeah, she'll be able to do that.
Okay.
I do see additional questions in the chat. I'm not sure if we want to.
Yeah, we don't, unfortunately, we don't have time to go over those questions, but we can get them the answers.
Okay. Okay.
We're gonna move on to Dr. Strauss. Thank you so much for being here with us.
Thank you for having me. I have an abbreviated presentation. It really focuses more on how do we design this process to allow it to be accessible to people. I did not focus as much on the data of the two gene therapeutics that are approved, and that's because originally Dr. Shaw was going to talk about that. These are my disclosures. I have research and then I do some consulting for some sickle cell companies, including Editas Medicine, which has a gene therapeutic under development. So I had three goals. The first was to describe gene therapies for sickle cell disease. That's just going to be one slide. And then I'm really going to focus on what are the barriers to treatment with these therapies and how can we help people overcome them and achieve equity, make sure that these therapies are accessible to people with sickle cell disease and as many people with sickle cell disease as want to have gene therapy. So this is what we do for gene therapy. It's an autologous bone marrow stem cell targeted gene therapy. So we start out with the person, and then we need to get their bone marrow stem cells. And how that works is that we, for both of the approved therapies, people are transfused for 2 months, and those transfusions help their bone marrow to focus on making stem cells. And then they come in to have the stem cells collected. And the way that works is that they get a medicine that tells the stem cells to leave their bone marrow and go into their blood. And we hook them up to an apheresis machine, just like we would do if we were going to do a red cell exchange and collect cells for 6 hours. It's a long collection, and sometimes people need to come back the next day and do it all over again. And if there aren't enough stem cells with the first collection, a month later, basically, people come back and do the same thing. Because we want to have a lot of cells because that gives people the best chance of having successful gene therapy. Then we send those cells off, freshly collected to the company, and the company fixes the cells in different ways. For Lyfgenia, you heard about how they add in a anti-sickling hemoglobin. They add that in using a lentivirus. And then the other product uses a different way of adding things in, but adds in a CRISPR-Cas protein, which causes a change in the production of fetal hemoglobin by changing something called BCL11A. And that leads to high levels of fetal hemoglobin, which is also an anti-sickling hemoglobin. As you heard, people with sickle cell disease serve as their own donor. So that means that everyone has a donor available. There's no need for the immunosuppression, the knocking down of the immune system that we have to do when someone gets a bone marrow transplant from a relative or from a matched unrelated donor. And there's no risk of graft versus host disease. So those are really the advantages. It still requires that people get the chemotherapy to knock down their bone marrow. And that is really the biggest challenge for most people. And then it comes back to the people. All right. Oh. All right. So there are really three main barriers to gene therapy for sickle cell disease. One is the history of racism and how that's affected people with sickle cell disease and systemic racism that still exists in how we provide health care. The second is money. These are expensive therapies. And then the third is really the practical challenges. So I think the people on the call know about how people with sickle cell disease can wait a long time in the emergency department. And we know it's longer than people wait in the general population to be treated with pain. And we think that's explained by race, that people with sickle cell disease are mostly Black, and Black people wait longer than white people. But we also know that people wait longer than other people that have long bone fractures, even after we account for race and triage priority. And we think that's stigma specific to sickle cell disease, that people with sickle cell disease wait longer than they should. And this changes how people approach their care. So a lot of people with sickle cell disease may delay their emergency department care until it's just they feel like they have to go. It's so bad, but they put it off. And this is strongest in people that have more frequent ED visits. And we think that's based on people's experiences with stigma and their low overall satisfaction with their healthcare. And why is that? Well, People tell us that their credibility or trustworthiness is often questioned by providers. And I certainly hear this from providers as well. When they request the medicine that works best for them, which is what I tell them to do and other sickle cell doctors tell them to do, they can be labeled as drug seeking. And in the words of one person, it's devastating for a person to be in pain but not to be believed. Makes you feel less than human. The trust is broken when the person you come to for help reacts negatively. We also know that people that perceive discrimination, more discrimination, that's associated with a greater burden of pain. So when we discriminate against people, it makes their pain worse. And that also leads to decreased trust in the medical system. And why is this important? Well, we're asking people to take a big leap of faith when we talk about curative or transformative therapies. There's scary things to think about. And then, what do we know about gene therapy for sickle cell disease? So we have limited data on long-term outcomes, and that I think is the biggest concern for some people. And we do know that there are certain risks, that the risk of infertility is substantial. It's a complicated and lengthy process. We want to make sure that gene therapy is safe for people, so we screen people for their lung function and their heart function and their kidney function, and that can take 4 to 8 weeks just getting those tests done. We transfuse people for 60 days before the collection. There's the collection of stem cells, anywhere from 1 to 3 cycles, and that's 1 to 5 days of apheresis, but we have to wait in between the cycles. And we hope that most people will be able to get this done in 1 cycle, but we know that some people will take more. The production of the modified stem cells can take 8 to 16 weeks. And most of that time isn't production, is actually after they're made, making sure that the quality is high and that they're going to work as planned. For people that need fertility preservation, that can take another 4 to 8 weeks. For women, less time for men, but that's also something that needs to be thought about. And that can be done while people are doing their 60 days of transfusion. The busulfan preparative regimen, the medicine we give people to knock their bone marrow down, is 4 days. And then there's a rest day. And then typically it's about 30 days for the white blood cells to come back up to the level that we would often think about sending someone home, and then up to 40 days for platelets. And this is for both gene therapeutics that have been approved. And then one of our concerns is that we want to make sure that there are adequate health system resources to support the process. So what's that process? It's getting all this scheduled, making sure that people can get there, that they have transportation, that they have support for hotel stays and other things. So there are high out-of-pocket cost involved with gene therapy because you have all these visits. Fertility preservation is not typically a covered benefit for many insurances. So that's something that we want people to be able to have as an option if it's something that they need. And then after they get gene therapy, there's also limited coverage sometimes for infertility treatment, especially in vitro fertilization, which is necessary for people that have preserved embryos. And in some states, there are barriers to even preserving embryos. At least in Alabama, University of Alabama recently stopped their in vitro fertilization program because of concerns over legal risks now that those embryos are considered to be children. And then you need time off from work for both the person that's going to be receiving the gene therapy and often a caregiver. And then there's overall less financial support for individuals with non-oncology conditions that require an autologous or allogeneic stem cell transplant, so one from themselves or from someone else. And that's not really equal. That's something that we would like to change and think about better ways to support people. So, what do we know about the clinical effectiveness? There are 2 separate products. Excuse me for 1 second. Guys, keep it down. So ICER, which is the Institute for Clinical and Economic Review, looked at the 2 gene therapeutics, and this is before approval, Lovo-cel and exa-cel. You heard about Lovo-cel. Exa-cel is the CRISPR-Cas9 product made by Vertex. And they compared it to hydroxyurea, chronic transfusions, chelation, and pain treatment, but not to the other new therapies for sickle cell disease. And they found a net health benefit for both therapies, so better than our existing therapies. but inadequate evidence to distinguish between the two therapies. And they calculated, they put a money value on it, 1.3 to just over $2 million, and recommended that the FDA label be used as a guide to coverage for the coverage policy. So what the FDA thought were the indications is what insurance companies should use. And then they also proposed the development of alternative payment models. Is there a different way that these therapies could be paid for over time by the government or other third-party payers, so it wouldn't be as expensive on the budget in a single year? And those are things that are being developed now by the Center for Medicaid Innovation, Medicaid and Medicare Innovation is working on that new payment model. So what do the labels say? So you heard about this: indicated for the treatment of patients 12 years of age or older with sickle cell disease and a history of vaso-occlusive events. So you need to have had a painful event or acute chest syndrome to qualify. That people should be monitored for evidence of malignancy through complete blood counts at least every 6 months, and something called integration site analysis at months 6 and 12, and then as warranted, really because of concern if someone had a change in their blood counts. And that also that patients with alpha thal trait may experience erythroid dysplasia that may require chronic red blood cell transfusion. I take that to mean that for the couple people in 100 that have alpha thalassemia trait, that we should be thinking about a different therapy. And then for Casgevy, which is the CRISPR-Cas product from Vertex, it's indicated for the treatment of sickle cell disease in patients 12 years of age or older with recurrent vaso-occlusive crises. So that means more, they need to be happening more than once, recurring. So one of the ideas that people have for gene therapy for sickle cell disease is that you really need to incorporate the effects on existing health disparities. And by that, I mean, if you look that people with sickle cell disease are being treated worse than they should be, they're not being treated equally now, that you should take that into account when you have a therapy that might be curative or transformative for their therapy, and that you should value that therapy more for these people. And so you can think of it as giving them extra credit for having gotten, having been unequally treated in the past, and also I think in the present. And a typical weight is somewhere in between 0.5 and 3. And what they showed is that if you used a weight of 0.9 right in the middle of that it made it really competitive from cost effectiveness. So this is a rationale that we should be supporting this treatment for people, even though it's expensive. One of the concerns, I think you heard that that Bluebird Bio has had a relatively easy time with getting coverage for gene therapy. But one of the concerns that I have as a healthcare provider is that there can be lengthy times to coverage decisions. And I think this is something that's really important to people. If they decide that they want to have the therapy, how can we minimize the time from when they make that decision to when they get the therapy? We also know that payers typically try to manage treatments that have high cost, and that may restrict treatment options for some people. They might be restricted to going to a certain center that's in their network. They might be restricted to a single product, or there might be limited support for the person getting the therapy or the caregiver for out-of-pocket cost. There are also practical challenges, such as limited access to comprehensive sickle cell care and referral. So we think these therapies are best given at treatment centers where people can get sickle cell care around it. And there also is increased risk of complications and even death in people that have organ dysfunction. So unfortunately, there'll be some people that, because of kidney disease or liver disease or lung disease or heart disease, that won't be able to tolerate the 2 gene therapies that are approved. And it's not really about the gene therapy, it's about the busulfan, the medicine that we need to give to knock down their bone marrow. It's just too hard on people as they develop end organ dysfunction. And there's also a concern that there might not be adequate reimbursement for the health system. So often there's a single negotiated rate for the entire process, and we really think that long-term follow-up is an important piece of that, and making sure that that's supported. I think that this might be especially important for people with sickle cell disease, because one of the things that we hope to see quite frequently is that people feel a lot better, that they can get back to living their lives, get back to work, and that some of those people may lose their insurance coverage if it's Medicaid or Medicare, as they find that their status is better. And we hope that they will be in jobs that provide good employer based insurance coverage, but that's not, we know from experience that that's not always the case. So we want to make sure that there's a way that people get long-term follow-up of their gene therapy and any other related complications, even if they do not have the same health insurance they had before. So one of the things that I was thinking about as I watched the presentation, and I looked quite a bit online as well, is how can we communicate about these therapies the best? And there's been efforts to make educational materials both by the companies that have developed the products and also by various other organizations. But when I looked, most of those materials are paper. And I know that when I go to look for stuff, I might want a podcast or I might want a video. So I think that we still need more of that. Most of the videos I could find about gene therapy were either really technical or news articles that didn't talk as much about what it's like to go through the gene therapy for the person. I think we need to have involvement of people's continuity healthcare provider, whether that's their sickle cell doctor or their internist, but making sure that they're included in the process, someone who knows the person well, both to advise them on what are the strengths and weaknesses of the process, and also to just be with them to be able to provide advice as they go through the process, because there's a lot there. We need an institutional and government investment in comprehensive sickle cell care. So we know that these gene therapies are transformative, but not everyone will be able to get them. And people need to have time to make that decision. So we still need comprehensive sickle cell care. And for people that already have damage from sickle cell disease, like hip or something else that might be causing chronic pain, we need to be able to provide the care for that after gene therapy. So far, I think there's been good health system investment to support establishing gene therapy. It looks good. This is a really hot area in medicine, so I think there's a lot of interest. I hope that interest is sustained. I really want to see that there's adequate support for long-term follow-up and fertility. And I think it's important that both the companies, the healthcare providers, the community-based organizations all partner together. And I've highlighted below the SC-RED, which is really focused on reproductive health for people with sickle cell disease, recognizing that that's can be an issue after gene therapy and bone marrow transplant for many people. And then assuring that there's adequate third-party payer coverage or foundation support for both out-of-pocket cost and costs related to fertility preservation and allowing people to have children after gene therapy, if that's what they want. I think that the continuity healthcare provider can also help people think about what it looks like, or their social work team when it comes to how do you manage being out of work for 3 months, or needing a caregiver for your children if that's your role. And then that institutional and government investment in comprehensive sickle cell care and the health system investment that I mentioned before. And then we've been thinking also about how do we develop other approaches to referral. So at least at Duke, we've decided that we're going to do combined sickle cell and gene therapy evaluation programs, where we want everyone seen by someone in the sickle cell program and someone in the gene therapy program. We want to incorporate the continuity providers by telemedicine potentially, but make sure that if someone's being referred from someone who knows them well, that we have their input. Considering gene therapy before people develop substantial organ dysfunction. So this is something that we're going to be thinking a lot about in teenagers and young adults. How can we provide adequate reimbursement to incentivize the transplant program? So to make transplant programs want to do gene therapy. And I think this hasn't been much of a challenge, but there was at least one major sickle cell program where the transplant program did not want to do gene therapy. And then to include financial support for long-term follow-up as we think about gene therapy. So it's recommended for 15 years, and this is the FDA recommended this for all integrating vectors and gene editing of hematopoietic stem cells. That should include evaluation for adverse effects of the busulfan, of the chemotherapy we give people. And we know that both products will have a 15-year post-marketing cohort where they follow 250 people, both for Lyfgenia and for the other product from Vertex, and making sure that how they're doing and what is going on with their bone marrow and everything else. And here are just some of the websites which have information about gene therapy. There's the Cure Sickle Cell Initiative, which focuses on both gene therapy and bone marrow transplant for sickle cell disease. The FDA website has a lot of information on the products, including recordings of the discussions that they had with their advisory committee. There's the National Human Genome Research Institute, which has sickle cell gene therapy education product, where they had a bunch of experts on gene therapy and experts on sickle cell disease, including people with lived experience, right? People that their expertise is having lived with sickle cell disease, sit down and really think about how best to communicate about gene therapy. They have some nice infographics, but I didn't see any videos on their website. But that website's there, and I can share these slides. And then there's SC Red, and you see their website there. And then these are our chickens. They give us lots of eggs. We're not allowed to eat chicken anymore in our household. My kids tell me, but they're pretty nice pets.
Thank you, Dr. Strauss. Okay, we know that Phil, you have to drop off, but Phil's team is here to answer any questions that you all have. If you have them for Bluebird Bio, please place them in the Q&A chat and we'll get them answered. And now we will also open Q&A for Dr. Strauss. We do have some questions here. And the first one in the chat was, how does this affect patients that take blood thinners already if it can cause clotting issues? And from a vascular aspect, would this treatment be possible for a sickle cell patient with multiple blood clots?
So I think it depends on the individual. We certainly do have people that undergo bone marrow transplant that have blood clots, either before or in the process of getting the transplant. Typically, we hold or reduce the blood thinner when someone's platelet count gets below a certain number. That number is usually 50,000. We'll reduce it, and at 20,000, we'll often hold the blood thinner for a period of time or support the person with platelet transfusion. It's pretty typical to get platelet transfusions after getting one of these gene therapy treatments, that most people need platelet transfusions because their platelet count gets low enough.
Okay, thank you. There was one more in the chat, and what's the minimum recommended age for patients?
So these therapies are currently approved for 12 years and up. There are ongoing studies in younger children. Right now they're looking at 5 to 12 for a number of gene therapies for sickle cell disease, or 5 to 11.
Okay, thank you. And then in the Q&A chat, the next question from Ashley Barber is, would an individual be eligible for either therapy if they have done an unsuccessful bone marrow transplant in the past?
Not currently at this point, because there's concern that that they will not be able to harvest enough stem cells. So those people were excluded from the clinical trials of both treatments, and would be someone that we would want to think pretty hard about before they would be considered even for off of a study now. So I think I wouldn't say never, but for as we start doing gene therapy in people outside of the clinical studies, we're going to mostly stick to the sort of people that they studied and then gradually expand. This is the way I see us using it. So right now we wouldn't want someone who had had an unsuccessful bone marrow transplant.
There was a follow-up question to that. People with sickle cell beta thalassemia wouldn't be considered for gene therapy?
They would be. So these therapies were approved for any type of sickle cell disease if people are having enough problems from it, is the way I think about it. And so that includes people with sickle beta thalassemia. I think that it depends on the details. If someone had sickle beta plus thalassemia and a near normal hemoglobin, I would be less convinced that they would do better after therapy than someone who had sickle beta null thalassemia and a lower hemoglobin, I think is more likely to benefit. So those are the individual conversations we might have with the patient. Unfortunately, for people that have established chronic pain that don't have a lot of ED visits or hospitalizations for sickle cell pain, that group wasn't studied. So we don't know how they would do with their chronic pain afterwards. For people that have mostly chronic pain, because that was a group that wasn't studied with either gene therapy.
Okay, thank you. And just two more questions. Would an individual be, I'm sorry, that's the one I just read. The next one is, when weighing risk versus benefits, on average, how many vaso-occlusive crises within a year to suggest that this may be beneficial?
Right. So I think that depends on how bad they are. But if you look at who was studied for both studies, people had to have 2 or more vaso-occlusive events that led to emergency department or hospital care per year for 2 years. So that's the group that was studied for these therapies, and those are the people that signed up to do the clinical trial. So that's who we'll be starting with, is people having at least two vaso-occlusive events a year for 2 years.
Okay. Two more in the chat, and I think we're gonna stop at 7:05 if that's okay. We went a little bit over, but we had a lot of some technical difficulties here. So the next question is there enough data to know if a certain genotype had better results?
So I think the short answer is no. There was that small group of people that had worse results, the people that had alpha thalassemia trait as well as sickle cell disease with Lyfgenia, and because of that, that's a group that I would not recommend. It's a small group of people, but we're planning on doing genotype for people that are considering Lyfgenia, and if they had that, we would recommend a different gene therapy product.
Okay. And the last question we'll take is, when did they start the study for patients 5 to 11?
Boy, I'm not sure. It's
Okay.
on clinicaltrials.gov, but I think it's been in the last maybe year or two. But that's the group that is still being enrolled, I believe.
Okay. And so we're going to end the Q&A with that. However, if you all have additional questions, please do place them in the chat now, and we will get them answered for you. And I'll hand it over to Jessica to close us out. Thank you so much, Dr. Strauss.
My pleasure. And I want to encourage anyone living with sickle cell disease that this is something that you should be talking about with your continuity provider, because they're the person that hopefully knows you and what's important to you the best, and that you can talk about that to have them help you think about it.
Okay. And before we end, Jessica, let me ask Bluebird Bio, did you have any closing thoughts or any questions that you wanted to circle back to before we close? Azizi or any of that team? Okay. Thank you all so much. Jessica?
All right. So yes, we are coming to a close. And I just wanted to thank you all for joining us this evening. If you were not here for the announcements at the beginning, please subscribe to our newsletter at www.bridgespointnc.org to receive updates regarding events. Once again, we would like to thank you, and I hope you all enjoy the rest of your evening.
Thank you so much.
Thanks for including me.
Of course. Thank you, Dr. Strauss, for joining us. All right.